Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. A 40-year-old woman presents with a 1-year history of weight gain, hypertension, and irregular menstrual cycle. Physical examination revealed that she had gained weight, especially in the face, okay, and of course in the trunk. Said that she presented with a moon face, and of course a buffalo, hump. Not only that, on the abdomen there were some striae or some kind of stretch marks over there. Now, laboratory investigation in the endocrinology laboratory revealed that she had an elevated cortisol levels. Meanwhile, imaging studies showed that she had an adenoma of the pituitary gland. So my friends, this is the case study we have before us. So the first question is, what is the most likely diagnosis as far as this patient's clinical presentations are concerned? My friends, your answer is hypercortisolism. Something we can say Cushing's syndrome. But precisely because there is that kind of adenoma, which possibly will be secreting out of ACTH, corticotropic hormone, then what's going to happen is that it is likely going to be a secondary Cushing syndrome or secondary hypercortisolism. If it had emanated from, of course, the adrenal cortex, the zona reticularis of the adrenal cortex, then that would have been what we call a primary hypercortisolism. So for now, it is hypercortisolism, and then it points towards secondary type. Now, looking at the presentations of this individual, what other presentations is it likely that someone with hypercortisolism may present with? Well, we talked about weight gain in this case study. Yes, we talked about the fact that be presented with this kind of moon face appearance. We talked about having that kind of buffalo hump. Okay, we talked about having some kind of striae or stretch marks on the abdomen, on the anterior abdominal wall, the skin over there. We said that one is going to happen. Now we said there's going to be hypertension. Okay, so these are things which we know already. But in addition to these ones, one thing that we'll be seeing is that this individual, may be prone to what we call, may have something like hirsutism. Okay, so growth of hair, excessive growth of hair. And that is why it is not surprising that this individual also has that kind of irregular menstrual cycle. So hirsutism is also one of the things that we'll be seeing. And not only that, osteoporosis, will be a complication that eventually may arise from this. Yes, if you are talking about the fact that this individual has hypertension, then it is also going to be prone to stroke eventually. Okay, that will also be one of the complications later on. It may manifest itself. This individual may have issues with carbohydrate metabolism, and especially may present with some metabolic disorders like diabetes mellitus. So these are the things that an individual can be prone to. Not only that, even prone to infections because the immune system will be down. One will be prone to infections, and then wound healing. It will be that kind of poor wound healing. So these are some of the things that this individual may present with. As far as talking about the hypercortisolism is concerned. Yes, of course, as far as the limbs are concerned, they will be thin. Thinner of these limbs will take place. So these are some of the things. Now, what is the basis? You want to understand what is the basis, what is the relation between the anterior pituitary gland, between the hypothalamus, and of course this adrenal cortex we are talking about. My friends, there's an axis, and that axis is called hypothalamic anterior pituitary And this time around, we are talking about adrenal axis. Which portion of the adrenal gland? We are talking about the adrenal cortex, not the adrenal medulla, adrenal cortex. And precisely, we are interested in the zona reticularis component of the adrenal cortex. So one thing is that we are aware that the hypothalamus, one of the releasing hormones it releases, as far as this case is concerned, will be what we call corticotropin releasing hormone. And so once it releases the corticotropin releasing hormone, it has that kind of direct effect on what we call the anterior pituitary gland, saying that to stimulate it to this time release, what we call the ACTH, that is adrenocorticotropic hormone. And so once that one is released, then it also has a stimulatory effect on the zona reticularis of the adrenal cortex. To this time around, secretes, this cortisol. And so one thing we are aware is that this, axis is tightly regulated through a negative feedback mechanism, such that, if you are producing more of cortisol, it will have inhibitory effects on the anterior pituitary gland, of course, what we call the hypothalamus, so that, of course, their secretions go down. But my friends, as far as this case is concerned, this individual has what we call an adenoma, okay, of the pituitary gland. And for that reason, the tumor in there will be secreting a lot of ACTH, and therefore will be having stimulatory effects, okay, persistent one, on the zona reticularis of the adrenal cortex to secrete more cortisol. And that's why eventually there's going to be that kind of hypercortisolism. So, of course, laboratory studies, okay, shows that there's elevated cortisol level. And then imaging studies is telling us that there's adenoma of what we call the adrenal gland. And so that is, the picture that I want you to, understand over here. Now, so as far as this one is concerned, so for instance, one may present with this cortisolism, okay, by having a head injury, okay, or by having, an issue with, of course, the adrenal cortex. If the issue is with the adrenal cortex itself, then of course we are talking about what we call primary hypercortisolism or primary Cushing syndrome. But if it is happening, okay, at the level of the head where we may have what we call the pituitary gland and pituitary gland, then of course it's going to be a secondary hypercortisolism. So my friends, these are the things which I need you to understand today. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.